Good afternoon, everyone, and welcome to today's program. My name's Laura Dixon, and as Harry has probably pointed out to you, I'm going to be your speaker for today. What we're talking about today is Joint Commission and the Patient Safety Systems chapter, and especially the Sentinel event policy that Joint Commission has out. Sentinel event is really a phrase from Joint Commission, not so much CMS. I'm going to give you some of my contact information. I'm also included email addresses for CMS. So what is the Joint Commission Sentinel event policy? And we're covering several components to this. First off, the policy and the patient safety system is designed to be used together, not independently, but together. These are the resources, how you find that Sentinel event policy. And the Sentinel event policy, and this is the most updated one. It's been amended, of course, many times with multiple changes to what that policy says. The definition of serious temporary harm. Now, this is Joint Commission. This is not legally based. Why do they call it Sentinel? I've included in here some information as the event policy according to your program. All right, what are the active failures? It's also been called the sharpened, more or less. The latent failures are those what was called the blunt end. So how do we fix them? How do we fix those latent errors? Well, we try to put up the barriers. Perhaps that computerized ordering system. What are examples of Sentinel events that we do have to evaluate? And of course, then you have your physical assaults on the patient, rape, assault, homicide. Now, as far as a response, patient safety event, that's pretty much a very broad term. And they talk about a patient safety program. The leaders, they're responsible for implementing that program. What must the leaders do? Put together that program. Always that blame-free reporting. What else do we have to do? Leaders, you have to define and communicate what's going on. Define what is a patient safety event. Then we look at what happened with this analysis, with this event. Support your staff. Joint Commission also talks about doing an assessment on your own. Be ahead of the game. Be a proactive risk assessment. So you analyze and use that information about your failures. Take what you've done, what you've learned, and disseminate it. Yearly, you send a written report to the governing board. Leaders are encouraged to encourage reporting, whether it's external reporting. And then, of course, that systems analysis approach. I'm just going to give you a couple examples of a systems analysis approach. Your action plan. What strategies, actions do you need to do so it doesn't happen again? You can provide an evaluation or response to Joint Commission to see what they think about it. How do you feel about how we responded to this event? So what about the impact of the event on accreditation? Systematic analysis. If you do report an event, your analysis will be reviewed to see how thorough it is, credible, and is it acceptable? Do a thorough analysis. Look at where you can redesign what's going on. It could help reduce, again, that series of 5 whys. So I've got a couple examples of some of the RCA tools. Some of these very familiar to you. We have the scatter plots. When Joint Commission wants to see an acceptable action plan, as far as follow-up, Joint Commission will follow up on your plan, your analysis and your plan, to let you know that it's acceptable. So when they do look, when a Sentinel event is reviewed, it's usually submitted as a self-report. You can also have an on-site review of the event if the response is unacceptable with Joint Commission. There is a framework for conducting an RCA. There's also the 18-page framework that Joint Commission has. What was the description? What was the diagnosis? What were the autopsy's results? So here's what one kind of looks like. They will notify the CEO that the event will be reported to Joint Commission for further review and follow-up. The on-site surveyor will assess your compliance with your standards, with the Sentinel event-related standards. They'll look at your processes on how you responded to that Sentinel event. I mentioned the Quick Safety. Joint Commission has what's called Quick Safety. It's a monthly newsletter, and it talks about an issue of safety. All right, let's switch over to the chapter on patient safety. In particular, it talks in the introduction, what are the core values, what are the systems, and why did they put this into place? Key terms, patient safety event. Becoming a learning organization. That's one where people learn continuously. What are the foundations? We want to promote learning. We always want to do that. We always want to keep learning. That culture of safety, that is an essential, critical component of making your whole system work. Staff who do report errors, learn from them. Staff leaders, they have to make sure that when there is intimidating, unprofessional behavior, that's stopped. And here's just some examples of what that intimidating, disrespectful behavior is. Joint Commission talks about the fair and just safety culture. Talks about accountability, that staff are human. When you are looking at accountability, use data. Effective data help you. There are key standards on data collection. Look at the effectiveness of medication management. You have to have data. And here's just, again, some more examples of those charts. How are you doing? Take it from data to information. Use a proactive approach. What are the benefits? Well, first off, your tools must come from a credible source. Peer review literature. How do you do this effective assessment? Determine why the breakdowns occurred. Get patients involved, patients and family. They need to be more involved in decisions about their care, and they're less likely to have an adverse event when they are highly involved. You might want to think about some principles. Focus on your measurements, your learning, and improvement. What about apology? And there's been some chatter on the ASHRM listserv right now about who's involved in this conversation when you do have to disclose, do apology. For what time is left, what I want to do is talk about now CMS, the conditions of participation. Is there evidence that leadership has set your expectations? Well, these are just some things you want to think about. Can your staff explain how they report an error? Is it phone? Is it computerized? Do they go to their supervisor? It overlaps with QAPI. Now, there's a memo that talks about adverse events. The hospitals, you are required to track adverse events. The IOM, they have a report that talks about the need for comprehensive, and then track them. The PI section does require you to track. I do want to point out, as far as the appendix, here are some of those patient safety tools that I had talked about. The AHRQ, patient safety culture. There's various ones. There's ones from England and others from the UK. I've listed out the National Patient Safety Goals, RCA 2, and also how that's like 50-some pages. Okay, and with that, I'll go back to the discussion with Marion. And again, if any of you happen to have suggestions, what can the hospital do? What should they be doing? And then I'll give you a little background information. Part of it was the culture and also leadership. Leadership wasn't really supporting them. And the culture was, and they felt big deal. They just went to the floor, we helped them down. So with that, again, thank you everyone for attending. Again, feel free to reach out to CMS Joint Commission, pose a question to them. Ask them, what is this? How are we doing in this response team? Is there something you suggest that we revisit? And otherwise, I'm going to turn it back to our moderator to go ahead and end the program.
Thank you, ma'am. So with this, we conclude the session for today. Thank you so much for joining today's webinar. Have a great everyone. Thank you.